Thank you so much for the invitation for the grant rounds, and thank you for that very kind introduction. My name is Natalia Serna. I am an assistant professor in the Department of Health Policy. And in my research agenda, I study how market and organizational factors impact patient and population health. So the project that I'm presenting today lies at the core of that research agenda, and it's titled The Role of Provider Networks in Individual Mortality. So the market factor that we will be studying are provider networks. So the motivation for this project is that in health systems that have managed care competition, health insurers typically compete on their network of covered providers. What does that mean? That insurance companies can decide over which and how many provider organizations to cover for their beneficiaries, and they're making those decisions with the goal of maximizing profits. What we know, so an example of that managed care competition I heard recently is, for example, Stanford Hospital is still in negotiations with Blue Cross Blue Shield over inclusion to their network. So imagine what would happen if Stanford does not reach an agreement with Blue Cross Blue Shield. What would happen to BCBS beneficiaries? So what we know so far from the literature is that there is a positive association between the breadth of those provider networks and premiums and healthcare costs. So that means that if you're enrolled with an insurance company that covers a lot of providers, you're more likely to make higher payments every month to your insurance company. And you're also more likely to make higher payments every time you go to the doctor in the form of patient cost sharing. What we don't know so much about is about the causal impacts that provider networks have on patient health. There is some work out there looking at the causal effects of the breadth of these provider networks on outcomes like healthcare utilization and healthcare costs, but we don't know so much about health. So in order to answer that question of how do provider networks impact health, we would need to have reliable data on the list of providers that insurance companies cover for their beneficiaries. And ideally, we would want to have an external factor that forces insurance companies to change their provider networks. We don't want their decisions to change their provider networks to be motivated by those profit maximizing incentives, but we want something random happening that forces them to change the network. So that external factor that I will be using in this project is the termination or closure of an insurance company. So from now on, every time I say the word termination, by that I mean a closure. So the first step towards answering our question of how do provider networks impact health using terminations as the external factor is to show that terminations actually do affect the decisions of remaining insurers in the market over how and over which and how many providers to include. So again, as I mentioned at the beginning, because my research agenda is focused on the role of market factors on health, here we're going to describe the market by the networks of providers that remaining insurers in the market are covering. The second step towards answering that question is to show that terminations actually affect patient mortality. And why would that be the case? Well, you can think that if an insurance company is closed, all of its beneficiaries are now going to search for other insurance companies where to enroll. And that influx of enrollees is going to generate congestion, which might hurt continuity of care and have downstream effects on patients. The final step towards answering the research question would be to combine those two previous steps to show how provider networks impact patient mortality using as external factor this insurer closure. But now you might be wondering, why do we need all those extra steps? Why do we need this insurer closure to answer the research question? Because another way to do it would be, well, let's take two insurance companies that cover different providers, have different breadths of their network, and let's compare the mortality rate across the two. Well, the problem with an exercise of that style is that healthy individuals are more likely to enroll with insurance companies that have narrow provider networks. Why is that? Because healthy individuals need less healthcare, they go less often to the doctor, and we also know from the literature that narrow networks charge lower premiums and healthy individuals tend to be more price sensitive than sick individuals. So by comparing mortality rates across insurance companies that have different breadths of the network, what you're actually doing is comparing mortality rates across people with different health status, which is not what you want to do. Ideally, what you would like to do is to do a randomized control trial where you randomize people across different insurance companies that have different breadths of their network, but that's very difficult to do. So instead, what the insurer termination is giving us is a randomization of changes in the breadth of the provider network. So the setting in which I will be answering this research question is the Colombian healthcare system. Colombia is a country in South America. This health insurance system offers coverage to nearly the entire population in the country, which is around 49 million individuals. Now, in this healthcare system, there is one national health insurance plan. So relative to the US, where, for example, here at Stanford, we have many plans to choose from, there you only have one plan. But that plan is provided through different private insurance companies, so you get to choose which insurer to enroll with. Now, almost every aspect of the national plan is regulated. For example, the premiums, which are the payments you make every month to your insurer, are regulated by the government. And also patient cost sharing, which is how much you pay every time you go to the doctor, that's also regulated. The only thing that is not regulated are provider networks. So that means that these private insurance companies can decide over which and how many providers to cover for their beneficiaries. So actually, this system is very similar in its market structure to Medicare Advantage and Medicaid managed care. So Medicare Advantage is a managed care system that bundles inpatient, outpatient, and prescription drug coverage, and it offers insurance coverage to people over the age of 65. Medicaid managed care is another managed care system where insurance is provided by private companies, offering coverage to low-income population in the US. So now the termination, or this external factor that I will be studying, is the closure of the largest health insurer in the country during December 2015, which was called Salud Cop. So the reason why the government terminated Salud Cop is because its board of directors engaged in illegal activities. They diverted over $250 billion to investments outside of the healthcare system. They also submitted false health claims to the government for reimbursement. And there are some news articles out there that say that its board of directors were also financing parties worth millions of dollars. So Salud Cop, again, was the largest insurer in the country. It covered 20% of the population, so 20% of beneficiaries. And it also had widespread presence in the national territory, so it operated in nearly half of all the municipalities in the country. You can think of a municipality being similar to a county. So, okay, on top of closing the insurance company, so this insurance company, Salud Cop, was vertically integrated with 38 hospitals across the country. And the government told Salud Cop, you also need to shut down your hospitals after December 2015. And as you can see from these pictures here on the slide, these are some pictures of Salud Cop hospitals in 2 cities in Colombia. These were fairly large hospitals, and they were very known for having these really wide facades. So the data that we have to answer this research question are, we observed the choices of insurer that every person in the country made between 2013 and 2019. So that's 3 years before and 4 years after the termination. We have health claims for the half of the population who pay payroll taxes. We also have individual level vital statistics for the entire country for the same sample period. And the anonymized patient identifier across the first 3 databases is the same. So that allows us to link enrollment with health claims with vital statistics. We also have very clearly documented data on which providers each insurance company was covering between the period of 2013 to 2017. Now, the methodology that we're going to use to answer a research question is called difference in differences. And what this methodology is doing is comparing outcome trends between a treated group and a control group before and after an event happens. So I'm going to explain very briefly what this methodology consists. So let's suppose we have this figure here on the left that depicts the outcome trend for a treated group in pink. and the outcome trend for a control group in blue. And now let's suppose there is an event that happens where this dashed black line is showing. So what the difference in differences methodology does is first, we're going to compute the difference in the outcome between the treated group and the control group before the event happens, and we're gonna call that D1. Then we're going to do the same after the event, and we're going to call that D2, that difference. So the name of the methodology comes because at the end, what we want is to take the difference of those two differences. And that is going to allow us to estimate the causal effect of the termination on the outcomes of interest, which in this case are going to be patient mortality. What is going to be the treated group in our study? Those are going to be the municipalities where this insurance company operated. And the control group are going to be the municipalities where it did not operate, that shouldn't have experienced any change to networks, any change to enrollment. So let's dive into some results. As I mentioned, the first step towards answering our question is to show that this termination actually affected the decisions that remaining insurers in the market were making with respect to their networks. So what I'm showing in this figure, in the horizontal axis is years since the termination happens. So we're looking at 3 years before to 1 year after. -1 is always going to be 2015. And in the vertical axis, we are measuring the change in the fraction of providers that insurance companies are covering. So if you see a positive number on that axis, that means that provider networks are becoming broader. Insurance companies are adding more providers to the network. If you see a negative number, that means that they're dropping for providers from their network. And what we find is that after the termination, as you can see in years 0 and 1, there is a substantial decline in the breadth of these provider networks. How do we put these numbers into something we can interpret? Well, those numbers are telling us that insurance companies were dropping 15 provider organizations per 1,000 enrollees. Now, you might be wondering, well, if I am an insurer in a market and one of my competitors is closed, why do I respond by dropping providers? Well, there is now a lot of evidence showing that insurance companies use their provider networks as a mechanism to select healthy individuals from the population because they are the most profitable. So if there is a competitor that closes, all of those competitors' enrollees are now searching where to enroll. And my response as a competitor is, I don't want to enroll the people who have chronic diseases who are potentially unprofitable. So I'm going to offer a narrow network to attract the healthy ones. So here is another thing that happens in terms of provider networks. Again, we're looking here at 3 years before to 3 years after the termination. And the outcome, or the vertical axis here, is the change in the number of visits per provider. So what we're finding here is that doctors are working more after this termination. So as you can see, 2 years after the termination, providers were rendering almost 20 more visits or consultations than what they were doing before. And this represents almost a 20% increase over what they were doing before. So we find that doctors are working more. And again, what can potentially explain the fact that doctors are now seeing more patients? Well, 2 things. One is that the insurance company to which this doctor is affiliated is dropping a bunch of providers from the network. So now, as an individual doctor, I need to treat more patients. And on top of that, there are all the enrollees from this insurer that got terminated that are being added to this new insurer. Now let's look at the second step towards answering the research question, which is there a direct effect of the termination on patient mortality? And so here, again, we're looking at 3 years before to 3 years after the termination. So this goes all the way to 2019. And in the vertical axis, we're measuring the change in their mortality rate. As you can see, after the termination, all of those estimates are positive. So mortality rates are increasing. How much? Well, we find that there is a 30% increase in the mortality rate. And you might wonder, well, that's a huge increase. I've never seen an increase of that magnitude. But you have to recall two things. The first is that this was the largest health insurer. If I want to bring it closer to home, that would be as if United Healthcare all of a sudden closed, or even closer to home, that would be as if Kaiser Permanente all of a sudden closed. Like what? How would the healthcare of the people enrolled with these insurers be affected? So we find a 30% increase in mortality, and again, we might wonder, well, why does the closure of our insurance company hurt patient health? Well, first of all, there is a period in which people might go uninsured. Second of all, it might be because of provider networks becoming narrower. If you're dropping providers from your network, what is going to happen to the people that used to get most of their healthcare at those providers? They're probably going to experience disruptions in their continuity of care, and that might have, again, downstream effects on health. But as I mentioned when I was introducing the setting, the government not only closed this insurer, but also the hospitals that were integrated with it. So you might be wondering, well, all of this increase in mortality can be explained by the fact that you're just closing a bunch of hospitals. So what would happen if Stanford Hospital closed? All of the patients seeking care there are going to be quite affected. But I can tell you that even if we exclude the elements, the units of our treated group where those hospitals were present, so if we exclude them from the analysis, we obtain the same results. So this is not being driven by hospital closures, it's being driven by the closure of the insurance company. Then we wonder, where is this mortality increase coming from? And what we find is that the mortality increase is coming from people with chronic health conditions for which an interruption in care can be potentially fatal. So for example, we find at least a 30% increase in mortality rates after the termination among people with chronic kidney disease, chronic obstructive pulmonary disorder, and people with any cancer. So these are the individuals who are being affected the most, who are also the ones that need more healthcare. Now, let's go to finally answering the research question of how do provider networks impact patient mortality using terminations as our external factor? And when we implement our methodology towards answering this question, what we find is that broad provider networks substantially reduce patient mortality. So here you can see that by the negative number here on the table. How do we put that number again into something we can interpret? So what we're finding is that if an insurance company adds 21 provider organizations to the network, this need not need to be big hospitals. They can be clinics, physician practices. If they add 21 provider organizations to their networks, they can reduce mortality by about 2 per 1,000 beneficiaries. And again, here, we might be wondering, what are the mechanisms through which a count of the number of providers that I have access to impacts patient health? And I can think of some, but of course, I'd love to hear from the audience about other mechanisms for why this matters. One of them is that changes in provider network affect the continuity of care for patients. Another one is that insurers that offer a broad network of providers are better able to treat patients with different conditions and are better able to steer their patients towards providers that might provide better care for them. So let me finalize by summarizing the findings. So what we're finding in this project is that after an insurance company is terminated, which is not something that is unique to Colombia, there have actually been like 9,000 plan terminations in Medicare Advantage. There have also been 27 plan terminations in Medicaid managed care. So what we find after that is that remaining insurers in the market respond by offering fewer providers to their beneficiaries. We found that doctors worked more. They were providing 20% more visits or consultations after a termination. We find that mortality rates increased substantially by around 30%. And most of this mortality increase was coming from people with chronic diseases who were dying at higher rates than before the termination. So what we're learning overall is that provider networks or the breadth of the provider network matters for patient health. So factors that affect insurers' decision over which and how many providers to include are going to have downstream effects on mortality. So when we're considering regulation that affects those decisions, we have to take into account effects on patient health. And some examples of those regulations that are becoming very common now across different health systems are regulations in the form of network adequacy rules that force insurance companies to cover certain providers. And that's it. Thank you so much for your time.
Thank you. Seeing those numbers on the screen are quite shocking. So while we're waiting for questions to come up on the Q&A, any questions in the audience? Dr. Vasquez?
Thank you very much for this. This is really important and so applicable to what we're experiencing with Medicare Advantage, like you said. As we all know, there is incredible publicity around recruiting patients and often misleading patients as to the networks. Can you say a little bit more about the efforts for regulatory issue? And I know that like the CMA is looking into this and so on, but it is so critical that patients totally experience what you described of lack of care for a long time, being assigned networks that are totally inadequate, yet being reassured that you are in the network. Thank you very much for this.
Thank you for your question. Yeah, so I know, for example, that only until very recently, CMS started requiring Medicare Advantage plans to make their list of provider available to their beneficiaries. But there is a lot of literature documenting that those provider lists have a lot of misleading information, something that scholars are now calling ghost networks. So there are providers that ensure that this Medicare Advantage plans list as being in network, but then when patients go there and seek care, they're actually out of network. So CMS is now starting to regulate this a little bit more. It has also tried to implement the same reporting requirements for plans in Medicaid managed care. But in Medicaid managed care, the problem is not so much about the breadth of the networks, but the fact that some providers do not take Medicaid patients at all. So there is a regulatory interest in making this provider list more standardized, but we're very far from getting there. And that's why literature analyzing causal impacts of provider networks on patients has been very scarce, because the data is not of high quality.
So thank you for this very interesting presentation. I wonder, is there a way to mitigate some of the effects of these insurers' termination on mortality and on physician workload by redistributing the work? Because the number of patients doesn't magically increase when these insurers close. They just go somewhere else for care. So what about those physicians who are now seeing fewer patients, et cetera? Is there some way to mitigate all of these effects?
That is a great question, and maybe I should have presented it. So we do have an exercise where we explore in what ways can we redistribute patients to remaining insurers in the market after a termination, so that doctors are not working more and we don't have these big impacts on mortality. So the answer to that question is that if there is an insurer termination in a market, you should redistribute patients to insurance companies that cover almost the same providers as the one that got terminated. Why? Because, well, if you reassign people to similar networks, they're going to likely experience fewer disruptions in their care. So that's going to have minimize impacts on mortality. And that's also not going to increase the workload for doctors, because they're going to be seeing the same number of patients before as after the termination. So what that means is that the policy that is currently implemented, at least in the United States, and actually Colombia started implementing this after more recent terminations, is not the policy that you want to be doing. So the policy that is being done is that after an insurer, after a health plan closes, you randomly assign people to remaining insurers. The goal of that random assignment is to minimize the fact that sick individuals tend to enroll with broad networks. So you don't want to leave all the health burden to insurers with broad networks. But by reassigning people randomly, you might still get a lot of impacts on mortality. You might actually want to reassign them to health insurers that have share similar providers in their networks.
Audience, I just want to follow up with I want to follow up with a question from the Zoom chat, which may be related to your answer. So Dr. Kwani says, really interesting work. Did you look at the change in travel distance to specialists after termination? Is it possible that patients had to travel farther to in-network providers and thus were less likely to schedule 10 visits? I know of interest to many of the specialists in this audience.
So unfortunately, the answer to that question is no, because in the data that we have, we do not observe the patient's residence address. We only observe the municipality where this patient is located. We do observe the specific address of the hospital. So one thing that we could do in order to answer that question is at least calculate distance between population-weighted centroids within a county towards each hospital. But yeah, we haven't done that, but I expect travel distance to go up.
Thanks for a interesting talk on a very important and interesting topic. I was wondering, it looked like the data set that you were using was based on this catastrophic loss of an insurer in Colombia. And if the conclusions can be more broadly applied to more of a steady state in terms of a network having fewer providers, it makes sense, but can we actually apply, it seems like it's two different things. One is what happens to the health of a community when a big insurer falls apart or just suddenly disappears. The other is a little bit more nuanced question, it seems, but I'm curious what your thoughts are.
Yes, so here, when we're answering the question of how provider networks impact mortality using determination as the external factor, I think what you're trying to get at is that there are many other ways in which determination can impact mortality, which is not the provider network, and that's not the effect that we are interested in this study. So we do check that all of the other mechanisms that you might have in mind for why determination might directly affect mortality, like congestion, again, that people with worse health conditions tend to enroll with broad network insurers. We check that all of those mechanisms are statistically not important once you control for the breadth of the provider network. But so it seems that in the data, all of these effects are being explained by how these networks changed after the termination rather than by other mechanisms through which the termination might have impacted the, mortality directly. So, so that, again, based on your question, that gives us a more externally valid conclusion, because if this project had been all about what happened after Salud Corp termination, well, we now know that these effects were very large, but an insurer termination of that magnitude is perhaps unlikely to happen in other health systems like the US or in Europe. So by estimating this effect of provider networks, which are actually very common across health systems with managed care, we're getting at some parameter that is more externally valid for policy across different health systems.
Thank you very much. Big topic to grapple with. And as you mentioned, you know, when Blue Shield or somebody suddenly is saying we're not covering a place, it's a nightmare for providers because the patients are really scared. There seems to be a little trend towards unionization of doctors. I wondered whether Colombia has unionization of doctors and whether it would have had any impact on this, or you looked at it.
So there is not, so sorry, this is difficult to pronounce. Unions of doctors are not illegal, but they haven't formed yet in Colombia. We have seen a little bit the data on workers, and here we have healthcare workers as well. And we do see that for providers that were doctors that were very specialized and that used to work for this insurance company and now had to look elsewhere to work, for them the salaries went up. But this is still correlational. We have no causal evidence on this. So it does seem that the termination has different impacts on doctors depending on specialties.
Thank you so much, Dr. Serna. That was a brilliant presentation. You delivered it so well, and it was extremely clear. So really appreciate you on presenting on such an important topic. One question that I had, sort of building off another question that was asked, was during that period where the insurance company had terminated, do you have a sense of how many patients or folks had sort of had lapses in insurance coverage and whether that sort of affected and played a role into the mortality benefit? I know you sort of mentioned addressing confounders, but what was that lapse in coverage like and how might that have affected?
Yeah, so this is another exercise that we did. So to look at how changes in the breadth of the provider network impact mortality, you want to see how the effect diverges between people who had a lot of their healthcare delivered at providers that were eventually excluded from the network versus people who had most of the healthcare at providers that remained in the network. So in the first group of people, the people that have most of their healthcare at providers that are excluded, that is about 10% of our treated group. So that would be around 400,000, no, a little bit more, like 1 million people. And these individuals, we see that all of the mortality effects that we're finding are among those individuals, the ones that their healthcare got disrupted the most because their providers were dropped. But for individuals, so the remaining 3 million individuals for which the provider remained in the network, we see no effects on mortality. So it's like 1 million people who actually experience interruptions in care versus 3 million who perhaps didn't.
Let's see if this won't work. So I'm gonna add a question from the Zoom. So thank you for sharing your interesting work. Dr. Serna, are there any sex-based differences, providers or patients?
No. So when we look at whether, when we estimate these mortality effects separately for men and women, we find the same effects. We do find different effects on mortality by age groups, but this is somehow also correlated with chronic health conditions that we saw at the end. So we do find that mortality goes up across all age groups, but it goes up by a higher magnitude among people age 60 and older, but no differences across sex.
Okay, we have one question from the chat that didn't make it into Q&A. This is from Dr. Dolezal. Wonder the impact of mass exodus and turnover of primary care physicians as little continuity of care and due to multiple issues, including in-basket more quantity versus quality of care. Will that likely impact mortality for chronic disease patients?
So we have also some exercises looking at what happens with the utilization of services that you would be claiming through primary care versus through more specialized care. And what we find is that there is a decline in utilization and spending across all types of care. So we find reductions in outpatient care, inpatient care. We also find reductions in the utilization of services that are perhaps associated with like appropriate disease management. So there is lower consumption of A1C blood tests for people with diabetes. There is fewer consumption of chemotherapy and radiotherapy among patients with cancer. Yes, so there is a reduction in utilization for primary care, but also like more complex type of care.
Hi, thank you so much. I'm wondering just with sex if there's also any socioeconomic differences for these patients, because I can assume if, maybe transport distance to hospital changes, folks who can afford to travel, maybe those changes get blunted a bit.
Yeah, that is a great question. We haven't explored, so we don't observe the individual patient's income level, but we can approximate that with the average income by age group and municipality of residence. That is a noisy measure, but we can definitely explore differences across municipalities in like through that measure of income, but we haven't done that. But yeah, I would expect that the mortality increase is probably explained more by people who are in the lower income level.
Thank you for your informative talk. I was wondering because this determination happened about like a decade ago, and with these huge effects on population, can you talk more about the situation today and what were their solutions to come up to incorporate?
That's a great question. So actually, so even though this termination happened, yeah, about a decade ago, in 2023, the government terminated another insurance company, almost of the same size. And the way they went about it, instead of reassigning people the way they did with Salud Corp, they now decided to reassign people randomly. We don't have the data far enough to explore that termination to see if the random reassignment was better in terms of mortality, but based on my earlier answer, my guess would be no. And there are, so the process that the Colombian government uses before like closing an insurance company is that they first send some agents to the insurance company to look at their financial statements, their balance sheets, and see how they're doing. And that process is called intervention. And right now there are two large insurance companies covering 50% of the country that are intervened. So there is a lot of turmoil right now in the country about what's happening to the healthcare system. And as I mentioned to my answer in another question, although a termination of that magnitude is unlikely to happen in the US, because in the US, a specific health plan doesn't cover that many people, whether you're looking at Medicaid managed care or Medicare Advantage. The disruptions in healthcare that happen after those terminations are the things that we might be worried about, and those are the things that we want to avoid. So that's where this research or this paper based in Colombia can help like policymaking here.
Thank you so much. This was really an interesting thing to think about. I think we see like very small scale things like a Kaiser strike for a few days, or some of the smaller hospitals in the area closing, and the impact that has on us as a very full healthcare system. And I can imagine something like this would be really devastating. And it also, the idea that doctors should just see 20% more patients is of course not going to be great. So just wondering about your thoughts about system, have you found as this paper came out and your work that there's any appetite for thinking about regulatory, if you want to get, patients in the United States, you need to have some sort of a plan for reassignment if you're dropping, is there any plan for regulatory addressing of these problems?
So I think the answer would be no. And the reason for that is because is precisely where this paper would contribute to the literature. So there hasn't, the reason for why there might not be any like regulatory change being discussed right now in the US is because there is no evidence documenting the causal impacts of these terminations on health. There is evidence documenting impacts on utilization and spending, and you might, through those findings, you might like extrapolate to what would happen to patient health. But other than like regulatory changes regarding how insurance companies or health plans are submitting their data on provider lists, there is nothing on how do we handle beneficiary enrollment after an insurer termination. And so what we're saying with this paper is, hey, you probably shouldn't do it randomly. You probably should do it taking into account which providers are included in which networks in order to guarantee continuity of care.
Dr. Serna, we need you to come this way so the Zoom
sorry.
people can see you as well. And since I've alluded to Zoom, I'm going to share a question from the Zoom. So Dr. Shah, who is our Community Engagement Associate Chair, has a question. I think is interesting. He says, beyond binary in and out of network, can you comment on tiers of network? So I'm sure it exists in Colombia, but here at Stanford, we encounter tier 2 or tier 3, which means officially you can claim in network, but requires a lot of effort, apathy to navigate the insurance with prioritizations to justify the needs of the patient.
Yeah, so what Dr. Shah is saying, we don't have tier networks in Colombia, but I believe that tier networks is a mechanism through which you can also gatekeep patients from the care they need by placing more expensive care in higher networks. I know in higher tiers. I know again that the reason for why insurance companies do that is also to contain costs, which is something that has been on the policy agenda of the U.S. government like for a long time and continues to be. But I think the experiment that we would like to do there is what happens if you drop providers from a specific tiers, and what happens if there is a provider covered in like tier 2 and tier 3. So if you drop that provider, how would patients in different searching care in different tiers would be affected?
I'll add another question, local question from the Zoom. Does your model assume that doctors, hospitals at baseline are as busy as they should be? In Santa Clara County, doctors' hospitals compete for patients by offering discounts to get insurance providers to send patients to their practices rather than competing doctors' hospital practices. Many quality assurance criteria suggest that busier practices, for example, based on number of surgeries or a surgeon performs, are associated with improved outcomes.
Yeah, so although we're not making the causal link of how the changes in how busy doctors are after the termination affect patient mortality, what we can say is that hospitals in Colombia prior to the termination were at capacity. So after the termination, when more patients are enrolling with a remaining insurer in the market from those which are coming from the beneficiaries that were previously enrolled with the terminated one, well, these hospitals have no capacity. And to the extent that we see declines in inpatient care, I think that this would tell us that like patient health is worsening after the termination. So I think the effect of doctors being more busy being better for health is not present, at least in this context.
I thought I saw a question in the audience, but in the meantime, I will share the question from Matt Stevenson, and then we'll come back here. So he comments, it seems predatory for remaining insurers in a network that has just experienced a termination to narrow its network. Are there any regulations to prevent this in the US or elsewhere?
No, there aren't. The only form of regulation out there right now that we also have, there's very little evidence on whether this works or not, are called network adequacy rules. And so these rules, for example, in 2016, CMS passed something called the final rule, where they were imposing the same network adequacy standards that they do in Medicare Advantage to Medicaid managed care plans. And what those network adequacy standards say is that you need to maintain a minimum provider to beneficiary ratio. You also need to maintain a minimum distance of travel between the population centroid of your beneficiaries and specific providers. So for example, I think it's half an hour for hospitals, maybe 10 minutes for primary care. That's the only type of regulation, but I think there are some articles out there documenting that the compliance of health plans with these network adequacy standards is very low, and it's very difficult for regulatory agencies to check compliance because the provider lists are also full of ghost networks, as some scholars call it.
Excellent talk. I'm going to recommend that they always have a long question and answer period at the end of grand rounds, because I think there's a lot of people in the Zoom audience and the real audience that would like to get some questions and answers done. Typically these end, you have 1 minute to do it. My question to you is, if United Healthcare Advantage plan came in and said, we're quitting, and you're the czar and you can tell them what they're going to have to do or what the United States is going to have to do, what would your recommendation be?
So my recommendation would be, you have to check what providers were covered by United Health, and then take all those beneficiaries and assign them to the health plan in their county of residence that has almost the same providers covered as United Healthcare did. So that's the way that you can minimize impacts on continuity of care and perhaps lower impacts on mortality. That would be the first best. The second best would be to reassign people randomly, as is done right now.
I'm gonna take the liberty of adding a question from the Zoom. I think you got at this a little bit when you talked about primary care and specialty care utilization, but if I paraphrase this question, it's essentially, did you track retention of physicians? So like here in the US, with the higher, you mentioned all the doctors work 20% more. And here we saw that with the pandemic, with women leaving medicine entirely, especially moms. Do you have a sense of how that was impacted?
That is a great question. So I guess the answer is no in this study. So when we were doing this study, we did not have data on like workers, but now we do. So that's something that we want to explore more, because there are very few doctors in Colombia relative to other countries of similar income level. I think that retention wouldn't be a problem, but that's just a hypothesis.
We're coming to the end of the hour. I don't want to leave the last question in the Zoom unanswered, so I'm gonna pose that one and then we'll likely close. Are there differences in cancer screening noted after closure? Any attempts to ensure continued screening?
Screening, that's a great question. I'm not sure that we looked at particular screening tests like pap smears or prostate cancer screening, breast cancer screening, but that's definitely something that we can do. Given that we see large declines in utilization of outpatient, inpatient, and different kinds of services, I wouldn't be surprised that screening for prevention of certain chronic diseases would also decline after the termination. Thank you so much, all of you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.